particular scan. So I hand over the session to Solav sir. Sir, please carry on, sir, with your presentation.
Thank you, Sharmaji. It's a pleasure to be amongst you, though remotely. Raghuji sir and Sharmaji have been very close friends over the last 25, 30 years in my practice. And thank you very much for your kindness. I would have loved to be present there in Solapur when Raghuji sir told me that this is actually, your monthly event. But it's indeed very kind of you to have, allowed me to make this presentation from Pune, the comfort of my home. And the topic, fantastic, Dr. Sharma ji. Apni buraiyan bataiye. That is what in short, And it took me quite some time to, sort of gather my wits and sort of compile this presentation. So, fallacies, the word implies mistaken belief or faulty reasoning. So when we believe that, a renal scan can do so many things and then you are taken by surprise. So when PET scan was introduced, it was most challenging for us to pass on the message to the referring consultants about its limitations. That's what I learned, because PET scan was introduced in Pune in 2007 and it was not part of our teaching curriculum. So, it was a big challenge for us to learn it and then unlearn certain misconceptions and then overcome our difficulties. So here are various situations where renal scans are used by the urologists or pediatric surgeons. So I'm going to cover up what are the tracers available to us, what is diuretic renogram. Today's topics is going to highlight the limitations of diuretic renogram in these situations. So people often ask me what is the difference between DTPA, diethylene triamine pentacetic acid, and EC or MAC3, that's ethylene dicysteine or mercaptotriglycine. So both of these are actually renal tubular agents. So they bypass the glomerulus while transiting through the kidneys. So in a patient who has glomerular dysfunction and where the creatinine is high, above 3, 3.5, and you still are interested in knowing whether the kidney is obstructed or not, the isotope of choice should be either EC or MAC3. EC is freely available in our country. MAC3 is made available in limited centers. Both are equally good as far as kinetics is concerned. DTPA is a poor cousin of inulin. So it has sort of gives you the glomerular filtration rate to not as accurately as inulin, but close to it. So it's mandatory in all patients with prospective renal donors to have absolute GFR of each kidney. That's where it is useful. Dimercaptosuccinate is a cortical radiotracer compound, which is once administered goes and localizes in the tubules, sticks there. So you acquire images. That's the gold standard for renal scars. Technetium per se can be used for its physical property when you are trying to do direct radioisotope cystogram. This one is no longer used because iodine 131 carries very high radiation burden. So as I said, DTPA, these are the indications. This is primarily in children and newborns. DTPA gives you very poor background, very, very high background and very poor target to background. So in newborns and infants, you should refrain from using DTPA. EC is the test of choice. And as I said, better resolution. That's gold standard for cortical renal scars. And of course, for localizing an ectopic kidney when other imaging modalities have failed. So errors related to quantification. This is a very, very important message, and I am going to highlight this in a couple of slides, intermittently. So importance of functional contribution is, of course, remains, but one has to keep in mind that your qualitative estimate of renal function must match the quantification which is derived by the computer, because computer doesn't understand the patient kinetics. The patient has moved under the gamma camera. The computer is not going to recognize this. If the patient's acquisition was stopped for some reason, the computer is not going to recognize, and if you draw a region of interest which is not accurate, the computer doesn't know whether the region of interest is outside the kidney or within the kidney. So these are all the areas where we may land up with incorrect, fallacious quantitative results. Coming to this example of a middle-aged lady with left hydronephrosis on sonography and thin cortex. Let's look at the quantification first. That's the right kidney. As we look from behind, it's laterally inverted as compared to an intravenous urogram, because the gamma camera is positioned in the lumbar region. So that's the right side, that's the left side. You can see that on percentage-wise, if you see the split function, it says 18% here and 82% here on the right side. The renogram curve is quite nice on the right side, and it's flat on the left side. Now, if you look at the qualitative images, the right kidney shows bright radiatress activity within first minute and goes on increasing uptake, and then shows gradual decrease as the isotope clears into the urinary bladder. What about the left side? The left side shows a cold area, and which does not fill up with tracer at all up to about 20 minutes. And in the post-void as well as delayed image, there is very little radiotracer activity in the left kidney. So qualitatively, this is nowhere close to 18 or 20% of functional contribution. So what went wrong here when the technologists drew an ROI in the left kidney? So if you draw an ROI which is large, if you draw a background area which is small, you are likely to land up with a overestimated functional contribution. The same patient's ROI was redrawn carefully, and you can see here the contribution is showing to be 8%. Actually, it is much less than 8%, but it is matching with qualitative. So it's very important that how the technologist places the ROI largely influences the functional contribution and the subsequent interpretation. So as a physician, it's important for us not to just report on the films which are provided. You have to go to the console, look for all these areas of pitfalls and try to correct them before giving a verdict. As I said, motion correction, ROI selection. If the bolus of radiotracer administered is improper, if there is extravasation of tracer in the arm, then the kidney is going to receive inadequate amount of tracer, and there is going to be prolonged successive absorption from the subcutaneous tissue, giving rise to falsely prolonged intrarenal transit of radiotracer. So tracer extravasation at every cost should be avoided. And of course, what remains in the syringe after having done the study has to be properly counted, because if you do not account for what remains in the syringe, then you may land up with false or incorrect GFR values, because the quantification is going to be erroneous. Between structural abnormality and functional status, this is a very important factor that as nuclear medicine physicians, we must understand our limitations. And we've had several times phone calls. I remember Dr. Rahuji will also remember कि undescended testis hai, whether you will be able to do a renal scan, I mean a technetium scan to look for undescended testis. Now, technetium scan is a very good tracer for documentation of a normally positioned scrotal testis for testicular torsion. It, by virtue of its physical property, it shows whether the testis is perfused or ill perfused. However, if it is not descended, if it's in the inguinal canal or anywhere in the abdomen, nuclear scan is not the test of choice because it doesn't localize in the testicle. It just shows you the perfusion in the normally placed scrotal testis, and absence of perfusion favors torsion, although the differential diagnosis of abscess tumor remains. So that's why where we have this limitation has to be understood. So coming to this patient, where an intravenous urogram shows bloated up pelvic calyceal system on one side, that's the left side, and suspicious of obstruction, although the middle ureter is seen, but there was a suspicion of obstruction because of this dilatation. So a diuretic renal scan was ordered, and look at the diuretic renal. Both the kidneys show equal uptake, almost equal uptake, 53, 47%. The peak is quite normal, and the half time T half is normal, and the renogram curve is downsloping. And this is the dynamic 30-minute acquisition shown to you in a cine format. Although the renal pelvis fills up with time, but there is prompt excretion after diuretic administration, which means this is an unobstructed kidney, and that ectasia which is seen is not functionally significant. Now, in the same patient, if you if you perform, the index of suspicion is high, then you repeat the study on another day using an F-15 protocol, because many a times the pelvic ureteric junction, which appears to be sort of narrow, may be able to handle volume of urine which is formed at normal laminar flow. However, when it is challenged with high volume with prior administration of Lasix, the same pelvic ureteric dynamics may fail to handle, and the obstruction may become manifest with high volume of load of urine. So that is achieved by administration of Lasix prior to the renal scan. And when you do so, can you appreciate that there is a pause, and after the pause, the frame has moved in the subsequent images. And this happens because in the F-15, we run the risk of overfilling of bladder midway through the study, when we need to pause the study, ask the patient to void, and unless of course you catheterize the child or patient during the scan, and then reacquire the scan. So you can see here, before the pause and after the pause, although the patient has moved, but there is complete clearance. So both the F+10 protocol and F-15 protocol, both of them have ruled out obstruction in the supposedly dilated pelvic calyceal system. So false positive for obstruction can occur if the patient is dehydrated, if the patient's renal function is impaired, if there's a massively dilated pelvic calyceal system, and I will come to that in a while, and if the patient's bladder, for some reason, neurogenic bladder, which can cause, overdensity bladder, which is not catheterized, can cause false impression of poor drainage from the kidneys. And a single kidney GFR, if it is more than 16 ml per minute, then the response for obstruction is fairly reliable. When the GFR is low, compromised, then of course the kidney refuses to respond adequately to diuretics, and we may not be able to differentiate between whether this is a parenchymal glomerular dysfunction related flat curve, or is this because of obstruction. And to overcome this problem, I already told you that one good isotope is a tubular secreting agent, which is ethylene dicysteine, or EC. Ethylene dicysteine, yeah. So caution while performing F-15 is early filling of bladder, because I just showed you that example. It may require indwelling catheter, and patient motion needs to be corrected while doing the. Now, here is an example of how the previous example was dilated system with normal drainage in both routine protocol as well as F-15 protocol. Here's a child who had flank pain, and the urologist called me after I gave a normal report that I am convinced that this patient has ureteric colic. And I'm not convinced that this patient has an obstructed kidney. What can you do? I said, I'll repeat this study without, of course, extra cost using an F-15 protocol on another day. So that because of residual activity in the kidneys on the same day, unless there's a substantial interval of about 4 to 5 hours, it's not worthy repeating immediately. So you need to, we call this patient on the next day and look at this. The right kidney shows good uptake and excretion, and the left kidney shows good uptake and poor excretion. There's progressive accumulation of tracer in the renal pelvic calcium system on F-15 forced diuresis protocol. The renogram curve is plumb normal. T half is normal, the uptake is normal, everything in the routine protocol. However, the same pelvic calcium system, the pelvic ureteric junction, refuses to handle the isotope in equal efficient manner as the right kidney on an F-15 protocol. And as you can see here, the right renogram curve is nice, now downsloping, and the left renogram pattern shows progressive accumulation of tracer after diuretic administration, which means this is an obstructed PUJ. That's another important message, limitation of renal. So that was an important, you can land up with a false negative PUJ if you do not take adequate precaution. And if you give up saying that no, patient symptoms are relevant, never do that. You must try F-15 wherever the clinical index of suspicion of obstruction is high. So that's the limitation of renal scan. Limitation of renal scan related to structural results. That's so very important. Here's an example of a patient whose MCU at birth was patient had urinary incontinence. MCU was normal. The patient had duplex system, and the patient was continuously wet. That was because the left ureter was opening into the vaginal wall. And on intravenous urogram, the upper moiety was all this information. Had it been hidden from me, I would have been totally lost as to what to read and make out of this renal scan. Now look at this. The left kidney appears to be smallish. The right kidney is normal, but uptake is normal on both the sides. And there is good excretion. And that's the post-void image. Between the post-void, and that's the renogram pattern. Left kidney shows the green one, nice uptake and excretion. The right kidney also is nice excretion. So where is the problem? In the delayed image, you can see the left ureter is visible. Normally, the gamma camera resolution is not at all good enough so as to be able to visualize normal, non-dilated ureter. So if you are able to visualize ureter on a renal scan, DDP renal scan with a gamma camera, then it means that the ureter is usually dilated. So here we went to the structural information which was available to us, that was the CT scan, and look at that. So that was a double moiety, and one of the moieties were, of course, ectopically opening, and the upper moiety, which was seen here, is actually dysfunctional. And that's the lower moiety. This is the left kidney, and that's the left kidney here. The upper moiety is not functioning, is not showing any function in the lower moiety. So if I had not had this information about the duplex system on, there was no way for me to know that this patient had duplex kidney. There was no way for me to know if the upper moiety is functioning or dysfunctional. So it's very important to have adequate structural information before going to read a renal scan. Difficulties in intermittent obstruction. This is extremely important message that I would like to illustrate using this patient, and it can occur in such situations where I just demonstrated one case, one or two cases with obstruction with F-15. The second is, of course, in a patient who has calculus which is floating, which can intermittently go and block the PUJ and cause obstruction. And the third, of course, is vascular. So here's a girl, example of a girl child who had left-sided mild to moderate hydronephrosis due to PUJ, and an initial DMSA scan revealed renal scars with 33% function. Then a diuretic renal scan was done subsequently in the month of November. It shows 35% function, suboptimally non-obstructed kidney. Then the patient came to us, and again, in about few months' time, and we said it's the same function, not much of difference. And once again, we said it is unobstructed. The patient returned in 6 months' time because ultrasound showed moderate hydronephrosis, PUG obstruction. IVU also revealed PUG obstruction. And we repeated the scan in September. And once again, I thought, and my team members thought, that we are dealing with unobstructed kidney. Let me show you all these cases. This is the one initially in the month of February 21. Nice downsloping curve bilaterally, T half is less than 10 minutes, unobstructed. Once again, although there is some degree of fullness on the left side, but in the delayed image, it shows progressive clearance. So that it's unobstructed. The KUB sonography shows PUJ. This scan was done in the month of September in 2021. Once again, good uptake, excretion, about 38% function. And nice excretion, T half is less than 10 minutes. Once again, unobstructed. Nothing in the delayed image. So we are convinced that we are dealing with an obstructed system. That was in September 21. And then the patient's referring physician called saying, now the patient is once again having more frequent symptoms than what she used to get. And would you please repeat the scan? So this was in about 6 months' time, in April 23, when the patient was very kindly referred to us. And look at that, the left kidney, if you look at the quantification, qualitatively, the uptake qualitatively is less as compared to the right side, and as compared even to the previous study. The previous studies, the relative uptake on the left side was better than what we see here. And on the sequential static images, there isn't adequate drainage from the left side, whereas the right kidney drains up. And that's the renogram curve. You can see here progressive accumulation on the left side, and the percentage function from 38, it had fallen to 33% or so. So we said, this time we said that, look at that, delayed image, post-word and delayed images. Both these images, they show evidence of obstruction. And so here at this point, we said subnormally functioning obstructed kidney, and a possibility of aberrant vessel needs to be ruled out because it appears to be an intermittent obstruction. And the surgeon was very kind to share peroperative images where there was a vascular, cause of the intermittent obstruction, which was subsequently relieved, and the patient was relieved of her symptoms. Now, can radionuclide renal scan document reflux in the same setting as a diuretic renal scan? And this question has been asked time and again. We have time and again said that do not worry about the money. We will, money is never a factor. What is important is getting adequate, proper result. So there are two methods of doing radionuclide mesochorionic reflux study. One is direct radioisotope cystogram, where you administer the isotope in the bladder suprapubically on a clean system without doing a prior renal scan, and then ask the child or the person to void in front of the gamma camera and require the full length of phase of acquisition. Extremely sensitive method because you acquire images at a rate of 1 second or even half a second per frame till the end of the voiding. And the indirect method is when you ask the child or the patient to void after having done a conventional renal scan, which is a less sensitive method because the isotope has already come into the urinary bladder, and some degree of isotope is going to be there in the background, which is going to vitiate with a low grade reflux, and some degree which is going to be there in the pelvic digestive system. Once again, it's going to blunt the sensitivity of the test. So here is an example of a 3-month-old child who had a normal MCU, because MCU you acquire only few images during the scan. And here the same child underwent a diuretic renal scan where excretion was pretty okay from both the sides, but the left ureter was prominent. You can see the downsloping renogram on both the sides. So it was, but in this image, if you see, there is some prominence of the ureter. So we suspected that there could be reflux. So how will you document? Will you ask the child, if you ask the child to void in front of the camera, in this status, the sensitivity is going to be less. So what we do is, we inject at this stage, after having acquired a delayed image, inject radiotracer activity about 3 to 4 times of what we use for renal scan into the urinary bladder suprapubically, so that there is nothing so that the bladder activity is overwhelmed to an extent that nothing is visible either in the background or in the kidneys. So here, you can see here, the same patient, the kidneys are virtually not visible. And as the child voids, there is nice reflux of tracer into the left side. So this child had left-sided vesicular reflux, which was manifest on direct isotope cystogram following a diuretic renal scan, but after having enhanced the urinary bladder activity. Now, can you detect reflux during the dynamic scan? That's possible when both the kidneys are functioning well. It's not possible, or you may only guess based on the renogram pattern intermittently. The renal activity fluctuates. You can only guess about it. But if the kidney is dysfunctional, if the functional contribution is about 10%, 15% or less, then you may be lucky that the retrograde flow of tracer to the affected side may be seen on a renal scan. Now, here is another example of a child who was suspected to be having PUG obstruction on ultrasound, and a renal scan was performed. And look at this. The left kidney shows good uptake, but the right kidney is showing subnormal uptake. And as you go towards the later part of the study, there is contamination. The child has voided. There is contamination in the perineum, in the diaper, and the renal and the ureter is prominent. You can see that here. So there is good uptake here. Excretion here, there is sluggish uptake, intrarenal transit prolonged, and there is sluggish clearance from the in the post-classics images. You can see the intrarenal transit is pretty. The T half is 29 minutes here. So are we dealing with a VUJ obstruction, or are we dealing with a vesico-ureteric reflux? If you ask me, I have no way of telling you. It could be either of the two. So that's a big limitation of renal scan, that you cannot dogmatically say that we are dealing with either VUJ obstruction or VU reflux. So as standard guidelines in the textbooks of urology and pediatric surgery, any patient with hydronephrosis, regardless of what other investigations say, a micturitic cystoarthrogram is an absolute must. It's required to rule out reflux before proceeding for anything else. So here we said subnormally functioning hydroureteronephric question mark. Look at that. This is what I have copied and pasted from what I had written in my question mark obstructive. I was not at all confident. Differential diagnosis, it could be vesicular reflux. And I asked for an MCU. And look at the MCU. There's a gross degree of vesicular reflux on the right side, same side. This patient subsequently underwent a DMSA scan elsewhere in Mumbai, and that was scars seen. And initially, working diagnosis for them was posterior valves, but later on, the final diagnosis was primary VOR with hydroureteronephritis. Patient underwent cystoscopy and circumcision. And subsequent to that, so that's about it. This is what was the story of. So between reflux, and reflux can be itself be of important cause of false positive result for obstruction because of intermittent backflow. So renal scans cannot diagnose post-urethral valve, even direct isotope cystogram. The direct isotope cystogram is a very good investigation and very sensitive investigation to look for reflux. However, when it comes to diagnosis of post-urethral valves, the test of choice is either MCU or cystoscopy. Nuclear scans cannot visualize or diagnose urethra and post-urethral valves. So, about the level of obstruction, can we be confident in defining whether it is PUG obstruction or VUG obstruction? Now, the answer is it largely depends upon what is the age of the patient. Here is a child who had gross hydronephrosis, thinned out parenchyma, and dilated renal pelvis. So either it was related to ultrasound said either PUJ or reflux. Creatinine was normal, MCU was normal, so it had ruled out reflux here. And that's the ultrasound, question mark PUJ, question mark. And a renal scan, you can see here, the left kidney is enlarged, it shows subnormal uptake, the intrarenal transit is prolonged. The renal pelvis is going almost, so you can see a renogram pattern is rising on the left side. It's rising here. This is nice downsloping. And the percentage contribution significantly compromised, 25% contribution. So these are the parameters you should look for when the result comes to you. You should look for qualitatively if the kidney shows uptake, equal uptake or not. If it doesn't show equal uptake and the result shows equal uptake, you have to immediately question your nuclear physician. Why, if I am seeing equal uptake here, why should I get disparate, result here? Or if you say, and this is how you have to, one, just 2 or 3 important things. Qualitatively, look at this frame. Quantification wise, look at the split function, whether it is matching with this. And the third thing is renogram curve, whether it is rising or downsloping. And look at that. By no stretch of imagination, I will be able to confidently tell you whether this is PUG obstruction or VUG obstruction. The only thing that comes to my rescue is an ultrasound and the MCU. On MCU, we have ruled out reflux. And ultrasound says, although ultrasound says either PUJ or VUJ, so we are not sure what we are reading, or reflux, we don't know. So here what I said is enlarged subnormally functioning hydronephrotic obstructed left kidney, normally functioning non-obstructed. Please note that the ureter may not be resolved well in the present scan. Sonography is suggested to rule out left hydroureter, thereby vasoaortic dissection. I have burned my fingers in early years of practice. I have been called obstructed system, although we never say whether it is, and the surgeon opens up and realizes, and the incisions approach is completely different. The VUJ approach is different from PUJ. So one has to, structurally define the ureter and acquire as many delayed upright images as possible so as to be able to look for dilated ureter on a renal scan. Though in this age group of 1.5 to 2 months is very difficult. So that's what we said. The patient underwent pyeloplasty because it was not a hydroureteronephrosis, it was only hydroid. And post pyeloplasty, the child underwent a renal scan. Look at that. Now, if you look at this kidney, there is so much better uptake as compared to the previous pre-pyeloplasty scan. Look at that. So much better. And the quantification wise also from 25%, it has jumped to 45%. So it's almost normalized. So in a growing child, it's extremely gratifying to relieve obstruction and to look for, you can expect good recovery in renal function, unlike in adulthood. And that's the delayed image, which shows no retention. So look at that. Pre-pyeloplasty, rising renogram pattern, post-pyeloplasty, nice downsloping renogram pattern, enlarged kidney, normal size kidney, subnormal uptake, fair degree of uptake. So good result post-pyeloplasty. So is it possible to detect ectopic kidney or is it possible to detect renal agenesis? Well, if the kidney is placed somewhere in the pelvis and if the bowel air prevents the sonologist from defining the kidney, and if the kidney shows preserved function then we will be very useful that either DDP or DMAC renal scan will very objectively be able to tell whether the patient has a functioning ectopic kidney or not. However, if the kidney is dysfunctional or non-functional, there is no way by which we can say if the kidney is absent or it's non-functional. So here was an example. Here's an example. The ultrasound showed agenesis of right kidney, and on a DDP, on an EC renal scanner, once again, sorry, the right kidney is not seen either in the renal pelvis or in the anywhere else. The uptake is good, and you can see that the renal, the ureter is dilated over here, and on subsequent, and the effective renal plasma flow, which we as a quantification is fairly normal, and there is although it appears to be downsloping, but the T half is prolonged. It's about 28 minutes. So anything which is more than 20 minutes is considered to be obstructed. And of course, there is a retention at the VUJ in the delayed image. Now, this is a very, very sensitive situation because the patient has solitary kidney, the patient has hydroureteronephrosis, and the function is preserved. Whether you will call this VUJ obstruction of a solitary kidney because you run the risk of doing a surgery on a single kidney, and God forbid, if something goes wrong with that surgery, the child may land up with secondary PUJ or reflux or whatnot. We never know. So, luckily, we called it hydroureter. Luckily, I got a follow-up only yesterday from the pediatric surgeon. The patient underwent reimplantation in October 2020. The child is now 5.5 years old, going well. Ultrasound shows reduction in diameter, and the EGFR is normal. So it's a very well performed, good decision, and effectively treated. So what are this is a very important message I would like to give to the audience about limitations of renal scan when it comes to post-pyeloplasty situation. If a patient comes to me with a paper saying this is post-pyeloplasty situation, the first question I ask is whether a pre-pyeloplasty scan has been done or not. And the reason is this. This patient underwent bilateral pyeloplasty. Before the pyeloplasty, the patient had obstructed kidneys bilaterally. Subsequently, one kidney was unobstructed on a renal scan, and the other kidney was normally functional. What happens subsequently is going to unfold. There are two scans, 2008, 2012, and then the third scan was in 2020-23. Let me show you one by one. Pre-pyeloplasty, both the kidneys are enlarged, right more than left. The function is worse on the right side as compared to the left. Both are showing central cord area, which is hydronephrosis. Both these cord areas fill up with tracer, which means it's a hydronephrotic kidney. And look at that. 45, 55. Both of them show obstructed curve. This is where the study was terminated. So do not take this as a downsloping curve. The study ends at 22 minutes, and that's why there's a false impression that it's downsloping. It ends here. So that's where you can see there's so much of retention. So post-pyeloplasty renal scan, that was in 2008. So immediately after within few months after surgery, you can see that the left kidney has normalized in size. The function has normalized on the left side. It was worse as compared to the right or previously. Both the renogram curves now are downsloping in pattern, but the right kidney shows retention. However, because the function is preserved, we say, and the renogram curve is downsloping, we say that perhaps we can closely follow up this in the post-pyeloplasty situation. It could be sluggish clearance. And a follow-up scan was done in 2010. So that was the 2008 and then 2010. Once again, both the kidney functions are preserved. Right kidney intrarenal transit is prolonged, as you can see here. So 55, 45. Now it appears to be obstructed, but in the delayed image between this and this, there is some degree of clearance. So once again, we said that this is a sluggishly clearing kidney. Its function is preserved. There are no UTIs, patient is asymptomatic. We can perhaps conserve and closely follow. So look at the comment. Normally functioning hydronephrotic, non-obstructed left kidney, hydronephrotic, normally functioning right kidney, no deterioration. Follow-up study is recommended. That's what we said. Close follow-up study is recommended. However, hereafter, the patient was lost to follow. And no, this was 2020. Then the patient came back in 2012, after to the 2010, 2012. So once again, the same pattern, obstructed system pattern on the right side. But once again, we said no deterioration in function, satisfactorily functioning hydronephrotic kidney, right kidney, no deterioration function, close follow-up is like 2012. Because the function was preserved in post-pyeloplasty, we said just be cautious, do not haste into intervention. After this, for almost 10 years, the patient disappeared. 2023, patient returns, and look at that. The right kidney is now enlarged. The function, which was 45 on the right side, is now 35. And the renogram curve also is obstructed. And between the between the post void and the delayed image, there is significant retention. So we said, this is likely to be obstructed. Please do a retrograde study. Because in a sluggish draining system, the only way to differentiate between an obstructed system and a sluggishly draining system is a retrograde study. So we insisted on the retrograde study, and there was stricture seen, secondary PUJ seen on the retrograde study. So that's a important limitation of a renal scan, that pre-pyeloplasty, the system is patulous and dilated. In a post-pyeloplasty situation, that patulous dilated system may persist for years together, and it may take a while. And one important parameter to know whether it's obstructed or not is functional contribution. If the functional contribution of the kidney deteriorates by more than 5% on a follow-up scan, that's an important indication of ongoing obstruction. Here is an example of left PUJ in a male child, in a adult male, where ultrasound revealed PUJ obstruction, dilated left renal pelvis, also dilated cortical atrophy. So they said this is PUJ. And on the renal scan, you can see here, there is subnormally functioning left kidney, which is hydronephrotic and obstructed. That's same reflected here. Functional contribution is 25. This patient underwent, you can see here, retention in the post-void and delayed images. And this patient underwent pyeloplasty. And post-pyeloplasty, if you look at the renal functional contribution, has improved to 35%. The counts between post-void and delayed have fallen. And if you look at the delayed image, there is some degree of retention still present in the post. But what is important here is, one is quantification, which I told you, and the second is, look at this line here. That shows the length of the kidney pre-pyeloplasty, and this shows the length of the kidney post-pyeloplasty. So here in this patient, before pyeloplasty, the function was compromised to about 25%. Post-pyeloplasty, it improved to a certain extent, but the renal size also decreased, which means there are two important parameters to suggest that though the pattern of renogram appears to be sluggishly draining, but functional contribution has increased and the renal size has decreased, these are important parameters to call it relief obstruction. If you had given me this scan without giving history of pyeloplasty, I would have called it obstructed. So that's very important. That's the important message and limitation of a renal scan while dealing in a post-pyeloplasty situation. The same patient, pre-pyeloplasty, post-pyeloplasty, you can see here, this is rising curve on the left side, whereas on this side, it rises and sluggishly clears. So fallacy related to percentage functional assessment pre and post-operatively. This is so very important. Now, this scan was done earlier on 2017, and you can see a region of interest on. If you look at the kidney qualitatively, the right kidney shows much less uptake actually as compared to the left. So this is an overestimated percentage function on the right side. So one has to be very careful in drawing the ROI. You can see here, the right kidney uptake is much less as compared to left kidney. So qualitatively, it is less. So quantification wise, it has to match the decrease. It can't be more than the left side. Anyway, so here the patient came for a follow-up scan to us, and you can see here in 2017 at 10 months of age, the right kidney is dilated. It shows obstructed pattern here, and the functional contribution is only about 27%. So what was done to this child after that's enlarged subnormally functioning hydronephrotic obstructed kidney? And pyeloplasty was done in the month of January, and subsequently the patient had a renal scan. And look at that. The right kidney is still dilated. It's still enlarged. It still shows prolonged intrarenal transit. The renogram curve, which was rising before, is now showing sluggish, drainage, those are downsloping, and functional contribution, which was earlier on 27%, is 30 now. It's almost the same. It's not much of difference between the pre and post. So if you look at this, there's preserved parenchymal function in this case, and improvement in drainage pattern, because the counts have fallen from 33,000 to 19,000 between post void and upright delayed images. So when you take a delayed upright image, the gravity assisted drainage shows you falling of isotope counts. It means that it's a successful surgery. So although this is a pediatric, no, this is an adult. This is adult or pediatric? This is a child also. So anyway, in pediatric, we normally expect good result after pyeloplasty, but in this, it was a disproportionately dilated patulous system. That's why the size did not recover rapidly as I would have expected, as we had seen in the previous case. So look at that. Renogram curve pre-pyeloplasty rising, post-pyeloplasty it's falling. Although the functional contribution is the same, but the drainage pattern has improved. So three important parameters we must look for when we are dealing with the pre and post pyeloplasty situation. One, has the drainage improved? Number two, has the kidney size decreased? And third, has the functional contribution improved or not? Had we not seen the pre and post pyeloplasty functional contribution as 27% properly, the patients, attendant may come, furiously with you saying that it was 50% to begin with, and now it's fallen to 30%. So you have to, and that's the fallacy of a renal scan, that if I, as a technologist, do not draw proper ROI, I may land up overestimating the function of the kidney. So that's an important fallacy of a renal scan. So you must draw ROI which are identical while interpreting, and that's avoid incorrect. Here is the last couple of cases. Flank pain, hydronephrosis. You can see here left kidney is compromised function, rising renogram pattern, obstructed system. Do you think this case of POG obstruction? If you agree, am I shooting? Is the time over?
No, sir.
Okay, so if often do you come across post-pyeloplasty with false positive results for obstruction? So if this one, you will call it obstructed because it's all showing, but if I tell you that this is a post-pyeloplastic renal scan, and if I show you this is the one which was done pre-pyeloplasty, then you will realize that the functional contribution of this kidney on the left side was 14% before surgery, and after surgery, it had jumped to almost 26%. So that's an important message, that functional contribution has improved from 14% to 25% on the renal size on the left side, which was obstructed. Look at that. This is pre-pyeloplasty. The kidney is huge. And post-pyeloplasty, although the function is compromised, it has improved as compared to the pre-pyeloplasty scan. The kidney size has decreased. Both these are important parameters for calling this an unobstructed system. If you do not provide me with this information, I will land up calling this renal scan as obstructed. So that's an important limitation of a renal scan. Male child, 2 subsequent studies, 3.5 months of age and 1.5 years of age. That's at 3.5 months. Enlarged left kidney, you can see here, subnormal function, hydronephrotic, and obstructed. And the same patient had pyeloplasty in December. Post pyeloplasty, look at the 2 kidneys. Both the kidneys are equal in size. Functional contribution is almost the same, 45-55. Nice downsloping renogram curve. And absolutely successful, charm to read a renal scan like this, where pre and post pyeloplasty. You can see here, compromised function, enlarged kidney, rising renogram pattern. All the possible 3 parameters are met with here. The kidney size has reduced, the functional contribution has normalized, and the renogram pattern has normalized. You rarely get to see this, but it's a pleasure to see this. And this is common to see in a growing child rather than in adults. In adults, you just get improvement in functional contribution, and you may get some improvement in renogram drainage. So these are the 3 parameters I already told you about. Coming to 2 or 3 important entities, renovascular hypertension and pheochromocytoma. This is a scan which was done earlier on. We used to do very often. Captopril challenged renal scan to look for renovascular. Functionally or hemodynamically significant renal artery stenosis is picked up. Here, the kidney refuses to show uptake, and on a baseline scan, which is without captopril challenge, it shows good uptake. For this to see, you must have a compensated renovascular abnormality, which means the kidney function should be really fairly well preserved. Decompensated renovascular hypertension may not show such good difference in uptake. And that's the renal artery stenosis diagnosed and treated. Iodine-labeled MIBG, you all know, is a highly specific test for pheochromocytoma. That's the tumor which is operated upon. But a word of caution, that's a paper in Journal of Neuroendocrinology on various radiopharmaceuticals for functional neuroendocrine tumors. So although the sensitivity, the specificity of MIBG scan is very high for pheochromocytoma, you must remember that the sensitivity is to the tune of 70 to 75%. So if your clinical index of suspicion for pheo is high, and if the MIBG scan is negative, do not write off the diagnosis. You have now new molecules in the form of somatostatin receptor analog. It's called as dotatate scan and an FDG PET scan. Both of them are non-specific. One localizes to the metabolic activity. That's the FDG PET scan. And which patient will show which isotope localization is extremely difficult to predict. For instance, this is from our own publication. The DOTA scan or the somatostatin scan is negative. That's the tumor, and the FDG scan is positive, and that's a flip-flop. Here is the somatostatin, which is positive, and the somatostatin positive, and FDG PET scan, which is not showing anything. So this is flip-flop. Sometimes you may have an uptake on FDG, sometimes you may have somatostatin receptor expression, and that's pheochromocytoma, paraganglioma detected here. And this is a paper in Asian Journal of Nuclear Medicine on FDG PET in localization of pyelonephritis. And nuclear medicine centers and PET scan centers are now coming up in tier 3, tier 4 cities. And I would like to congratulate the citizens of Solapur that you have a nuclear medicine center, you have PET CT. And this is a beautiful saying which I came across on the streets of Seattle. A flower does not think of competing with a flower next to it. It just blooms. So we all should enjoy our work. There is enough of work for all of us. And I must thank Dr. Sharmaji, a very close old friend of mine, a fabulous human being, Dr. Raghuji sir, for being here to attend, and all of you for sparing your valuable time and allowing me this place. I would have loved to visit Solapur If only Dr. Sharmaji had told me that please come over only once, I would have jumped to it, to the opportunity, and it's a good break to catch up with few friends from time to time. Thank you, sir, once again, and looking forward to meeting you in person sometime in future.
Thank you, sir. Thank you for an extremely informative talk. As expected, it was full of knowledge and it cleared a lot of our doubts. Regarding an invitation to be physically present, I think you uh, definitely need a bigger audience. And we are planning for a CME and we will definitely have your presence over there. So that
Thank you, sir.
we would be benefited by the immense knowledge that you are having in this field of nuclear medicine.
Yeah.
I would now request any questions from the audience. There's a question from Dr. Akshay Patil. That do you sedate the patient while doing urine rounds? Do you routinely sedate the patients while doing urine rounds?
Never. The only situation we sedate the children with pedichloral is infants. In infants, we have to avoid motion, and the best way is to identify, to breastfeed them, identify the natural sleep, and at the most give a few drops of pedichloral before the procedure, and inducing natural sleep is the best way of acquiring a renal scan. Pedichloral is the most. We don't induce anesthesia, although maybe once in a while we might have used ketamine, very, very rarely. Otherwise, if you counsel the child properly, the parents properly, we all invariably allow both the parents to be present during the scan. So it's needless, to keep them away. They must be, familiarize them with mobile phones and nice cartoons which are distracting the children. It's and if you secure the IV line beforehand, before going into the gamma camera, before the painful injection, I think there are ways to distract the child, and we try as far as possible to have natural induced sleep, and at the most pedichloral, but do not use ketamine routinely in our practice.
Dr. Solav.
Yes, sir.
I'm Sanjay Deshpande.
Yeah, I recognize you. I recognize you, although all the images. Yeah, tell me, sir.
Yeah, what I want to ask is, Gyanendra Sharma has done extensive study on interpreting nuclear scans in PUG obstruction patients. And he has come up with in equivocal cases, there is a role of measuring cortical transit time.
Yes.
So you are not mentioning about this. So I would like to know your views.
Cortical transit time is actually a visual assessment. You need to see, it's not a quantification by computerization, it is a visual assessment. So if the cortical transit time is prolonged, it's of course an important indirect indication of obstruction. That is one parameter. In pediatrics, I did not cover on what is called as NORA, normalized residual activity in the kidney. If it is more than 1.2 normalized residual activity in the kidney, if it's more than 2 at 60 minutes and 90 minutes, that's important parameter for obstruction. So these are some quantificative parameters which you can add on, but more important, of course, these help you interpret the renal scans, and NORA also helps you. Cortical transit time, we have done with Dr. Sharma, so many cases. I invariably give cortical transit time on all his patients. Percentage retention in the renal pelvis after Lasix is also important. These are important quantification parameters which add on, but qualitative assessment of the renal, and of course combining it with the clinical data. For instance, I have shown you a couple of cases where post pyeloplasty, there is a false impression of obstruction on renal scan unless you compare it properly with a pre-pyeloplasty. This abnormality is going to persist, and perhaps your quantification parameters will not help in overcoming them. So, putting everything together is very important. And yeah, I agree with you that as much quantification possible has to be incorporated in our reports. I agree with it.
Thank you.
Sir, your experience about false positive cases in neonates and infants, which we should be worried about before proceeding for surgery, especially in neonates and infants?
Can you be little loud? I couldn't hear that question clearly.
So the question is, what is your take on false positive findings in neonates and infants?
Well, it is not to be called as false positive. It has to be, yeah, you may call it false positive. The fact is, in infants and neonates, actually, I did not show that particular. If the renal function, the dictum is very simple. In neonates, if the renal function is preserved, if the renal tubular function is equal, it's preserved, if the absolute effective renal plasma flow is normal, regardless of what the renogram curve shows, you conserve, you follow up with ultrasound AP diameter and follow up with renal scan at 3 months, 6 months, 1 year. And more than 50% of these patients will show normalization of renogram pattern because the tubules are immature in this age group. And if the function is preserved, there is no need to intervene in this. I know it's a well-established fact that pediatricians, pediatric surgeons, you all know this, that if the function is preserved, regardless of what the renogram pattern is, if it shows obstruction, you have to ignore it because it's going to show obstructed pattern in view of immature tubules. And as the child grows, the tubules mature, the drainage function improves, and majority of them, 50% of these renal scans show normalization of drainage pattern with time. So it's to be, if we know the important, it's a very important limitation, but we have an important parameter of quantification parameter with us to pronounce our judgment, and which is functional contribution and absolute effective renal plasma flow. If both these are normal, we ignore the renogram pattern. There was a debate or sort of tussle we had in January midwinter meeting of US. They frequently practice catheterization in children, and I am vehemently against catheterization. There is another Australian colleague of mine who is also vehemently against catheterization, because when we know that the functional contribution is and effective renal plasma flow are going to decide our decision, going to influence our decision on management strategy, it's needless to try to catheterize and try to artificially, we are fiddling with the physiology by catheterizing, by giving an unpleasant experience to the child feels, terrible. It's a very messy procedure. The isotope gets contaminated all over, and you run the risk of contamination of the gamma camera, the table, etc., etc. It's a messy procedure. That's number one. It's a traumatic experience for the child. And very well knowing that our decision is largely influenced, irrespective of what the renogram curve shows. Yes, Americans are right to the extent that if you catheterize and if you show that it's draining and it's unobstructed, you avoid a second study, because then it's needless. You can just do a follow-up ultrasound. But here our point is, when you know that regardless of what the renogram pattern is, if functional contribution remains same, if the function remains preserved on follow-up scan, there's no need to intervene. And that's what I follow. I don't catheterize the children unless you are suspecting VUG obstruction. In adults or children where you are suspecting strongly VUG obstruction, you must catheterize.
Dr. Solav, sir.
Yes, sir.
Two questions away. One is pre-pyeloplasty and post-pyeloplasty. After the repair, if relatives ask, is there any chance to improve the function of this patient?
because few of the slides, there was minimal improvement was there. So what should be our answer to the relatives? One. So anything highlighting about this, or dogmatically we can say that he doesn't going to improve and it remains static.
So
Because
there we are
ask questions.
post pyeloplasty. There we are looking at three parameters. One of and fourth parameter, which of course you know better, is the patient's clinical improvement. If the patient's symptoms, recurrent UTI has subsided, if flank pain has gone, that is clinical. That is in your jurisdiction. If the function remains preserved, you have done a successful surgery. If the renal size has decreased, you have done a successful surgery. If renogram pattern normalizes, it's a successful surgery. If it's combination of all the three, all the more better. So we have to tell that it's like a balloon. An uninflated balloon is going to be always shrunken and normal in size. Once a balloon is inflated, it is never ever going to return to its original size. So the ultrasound continues to show for its life. Ultrasound is going to show pelvic axial dilatation because the kidney elasticity is lost to that extent. So hydronephrosis is going to remain in many cases for life. As long as the function is preserved, we do not want to sacrifice the kidney. As long as the child or the patient is not suffering with recurrent UTI, you're happy about it if the patient is asymptomatic. If that patulous system becomes a harbinger of infection, recurrent infection, then, and if the function is deteriorating, and if it's not coming under control with antibiotics and required treatment, then of course, you have to think in terms of salvaging, sacrificing the kidney. Not otherwise. We have to warn that's why many a times, if the patient has undergone surgery in the past and doesn't have a pre-pyeloplasty record, it's a very frustrating situation for us. As a nuclear medicine, I always write a rider at the end if I do not have a pre-pyeloplasty scan, that such cases must, if it's an abnormal scan, it may not be an abnormal scan. It appears to be abnormal because that's a limitation. That's a limitation of the renal scan. It's not a limitation of the renal scan. It's the real kinetics of the tracer happening in the kidney despite surgery, despite a successful surgery, because the kidney is structurally altered, because the flow is sluggish, and it's what you see is what is happening in the patient's body. You can't help it. It's it's natural disease process.
The second one, whenever there is evidence of huge obstruction is there, measured
A bit loud, sir. A bit loud.
Hello. Whenever there is a
Yeah.
case of huge obstruction, can you listen now? Hello.
Yeah, yes, I can hear you, sir.
No, huge obstruction. So when we clinically diagnose, and many of times without bypassing the IVP, we do a DTPA scan. Because by ultrasonic report, we see. But sometimes if we do IVP of these patients, we can diagnose aberrant vessel pre-operatively also. Because what cutoff sign you get in PUJ, you may not get in an aberrant vessel. So this is, I personally found, 1 in 10 patient, 1 in 11 patient, we do come across in on the table, we can't aberrant vessel because 1 cases in 10 cases of PUJ obstruction. So if the vast experience of yours, can your DTPA or can your any clinical study shows he can enable this patient as a aberrant vessel or this patient as a huge obstruction? Because we see clinic sonography, we see IVPs, we see DTPAs, because all serial investigations we do. But probably when you do examine, you ask patient to have any other investigation done and you would like to see it and differ opinion about yours. Anything is there like that.
The question I could not entirely unfollow, but anyway, IVU, you are trying to say if the IVP shows clear-cut PUJ obstruction, what is the need for renal scan? Is that the question, sir?
No. That can clinically, pre-operatively, can you diagnose the obstruction because of aberrant vessel or?
No. It's we cannot. We can only suspect. We cannot. In this case, which I had illustrated to you, there were no calculus over there. The previous scans were 3 or 4 successive scans were normal. Patient continued to be symptomatic, and the referring doctor also said that we cannot diagnose it. There is no way we can look at the structure of the vessels on a renal scan and pronounce vascular abnormality at all. It is to be done with conventional radiology and with in your per-operatively you define it. We cannot pick it up. We can only suspect.
No,
You cannot.
because when we suspect pre-operatively, totally our idea of operating everything becomes changes. So in that case, because at least 1 in 3 IVPs, at least obstruction has got aberrant vessel. So
I have not understood that clearly. Actually, I could not hear you clearly. But are you trying to say that 30% of IVPs show evidence of aberrant vessel? I'm not sure what you said. Asked.
No. Even I will ask my colleagues also. Who want to say that I'm seeing the LV X-rays, if this patient has got an intrinsic or extrinsic obstruction because of vessel. Can discuss anything. What I mean is because we see so many cases of future obstruction in open, there will be aberrant vessels.
There is an aberrant vessel. There is no way we can. There is no way a nuclear scan specialist diagnose aberrant vessel on a renal scan. There is no way we can do that. It's just you can suspect because it's an intermittent. You can't even suspect it. Actually, you can only guess it could be.
You can arrange scan suspect. What is your experience of pre-operative? What is telling is, previously last 40 years we didn't have CT there. But classical findings because of the great deal of obstruction you can see, and the aberrant vessel obstruction you see, there is enormous difference. Of course, sitting supportive evidence are there. I don't mind about that, but we never last 15 years, first 15 years, we have not seen any CT or CT angiols. But previously we used to think, but 1 in 3 patient you are always right, because by seeing this. That I'm asking the experience.
It's somehow I don't know. I couldn't hear that clearly. Today's lecture is on fallacies of renal scan, and the important fallacy, important limitation of a renal scan that it cannot pick up structural abnormalities. As I illustrated in one of the cases of duplex system, we would be in no position to make the diagnosis of duplex unless, of course, you have 2 distinct, separate, moieties away from each other. So you need to have, and furthermore, if you want to define split function between the 2 moieties, it's all the more important to have. We invariably do a CT scan to look for the kidney moieties sizes before drawing a region of interest between the upper and lower moieties and defining the split function between the 2 moieties. So structural resolution is a huge limitation within conventional nuclear scans.
Hello. Sir, this is Dr. Deshpande. Hello.
Yeah, please.
Can you hear me?
Dr. Deshpande.
Sir, this is not related to today's topic, but I would like to tell you that can you tell us something about the role of radionuclide scan in post-transplant patients?
Oh, thank you. Yes, that's a very important area where nuclear, I mean, a DTPA renal scan or the EC renal scan. Of course, one is, of course, to look for urinary leak, to look for urinomas. It's very objective, bit to differentiate between seroma and urinoma. Number two, for looking at to differentiate between acute tubular necrosis and rejection. So if the perfusion, so here one important technical challenge is when you are doing the scan, the bolus of tracer has to be extremely small and extremely rapid, because the vasculature of the transplant kidney is highly, decisive about the situation being either rejection like or ATN like. Because in ATN, the perfusion is usually preserved, and in rejection, the perfusion, and it's very qualitative. So if the perfusion is hampered in the initial few frames, the transit from aorta to the or the common iliac to the transplant, if it is diminished, you can suspect that you are heading towards rejection. Otherwise, if in the initial post-transplant period, the two important differentials are acute tubular necrosis, which has relatively good prognosis, and transplant, of course. And the final, of course, decision depends on the biopsy. But one important parameter which you, as a practicing nuclear medicine, has to look for is the perfusion of the transplant. The perfusion is well maintained, we are unlikely to be dealing with a rejection situation. It's more likely to be either drug-induced. We have seen a lot of drug-induced renal dysfunction, reduction in doses. The immunosuppressant drugs can sometimes interfere with function, and it either that or ATN, and both of them they recover well.
Thank you.
Thank you, sir. Thank you for an excellent talk and an excellent interaction.
Thank you for the opportunity.
Sense of time, I think we need to call it a day. We are extremely thankful to you, and you made us realize that even though a lot of people are under the impression that it's just giving a radionuclide tracer and calculating certain things based on a computer, it's the man behind the machine who is equally important, who correlates everything with the clinical as well as other radiological parameters to come to a correct conclusion.
No, young students are coming out very skilled. They are trained at extremely good centers. I am proud to mingle with them, to chat with them. People are trained at All India Institute, PGI. I still refer to my colleagues in higher centers from time. At least once a week, I refer to somebody in PGI, somebody in AIMS, somebody at Jaslok ki baba is patient mein kya ho sakta hai? Because learning never ends, and it's always wise to have another opinion. And that's why I have huge respect for surgeons. I have huge respect for pathologists. The one important reason is the best of the surgeons do not hesitate in calling in their colleagues when they come to, complex surgeries. The best of the pathologists, I have seen them writing a report saying that I feel that this is so-and-so, but a second opinion may be away. So I think as human beings, we have our limitations, and it's in the interest of the patient that we should offer our best. I consider my colleagues who are 20 years junior to me in my clinic as my colleagues, and I ask them to review every single case, and I give them a pat if they come up with an opinion which is different, because that's in the interest of the patient, and that's what is required to have an open mind and to do the best for our patients. Thank you for the opportunity, Dr. Sharma. As usual, I definitely would like to, come over just socially to have a cup of tea sometime.
Definitely, sir.
Thank you. Can I leave now with your permission?
Yes, sir. Thank you so much, sir. Thank you.
Thank you. Bye. Bye. Good night. Good night. Thank you.